Marie Curie Hospice Penang, and her current area 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 Good evening. My name is Faris Hussain, and I'm one of the Medics.Academy and FDocs team members. Tonight, I am introducing our speciality webinar speaker, Dr. Sharon Seaman. Dr. Seaman is a consultant in palliative care based in Cardiff, currently working in Marie Curie Hospice, Penarth. And her current areas of expertise include quality improvement within palliative care, motor neuron disease, and corneal donation. Having been mentored by Dr. Seaman as part of my Year 4 student selected component whilst at medical school, I am thrilled to be able to introduce her talk titled A to Z of Palliative Care. If you have any questions during the webinar this evening, please post them in the dedicated Slack channel. The channel for tonight is #PalliativeCare and can be found on the FDocs Slack. I hope you very much enjoy the talk. Over to Dr. Seaman.
So I've chosen an A to Z format for this evening's talk to try and get across as many key messages from the palliative medicine world as I can. And in preparing for this session, I've gone to my junior doctor colleagues here at the hospice and at the local hospital and our specialty trainees in South Wales to ask them what they would have most liked to learn about as an F1 doctor, and also what they find themselves spending the greatest amount of time talking to junior doctors in their settings of work about. So I hope that means that you'll find this session very relevant. It is, I will warn you, quite a whistle-stop tour of the whole of palliative medicine. So we'll get started. So I'm going to start with A for assessment. And this is critical, really, when you're asked to review any patient with any symptom, to first, before going in and thinking, oh, I know an antiemetic I can use for this patient who's nauseated, to first assess the patient and think, why is this patient nauseated? How long has this been a problem? What have they tried already? Why do I think this is happening? And then, okay, this is what I'm thinking, therefore, this is what I'm going to try to help this patient. If we do good assessments of our patients, we are far more likely to commence the correct treatment for them sooner rather than later. And there are lots of different assessment methods, but for physical symptoms, systems like SOCRATES or PQRST work well. So SOCRATES stands for site, onset, character, radiation, associations, time course, exacerbating factors, and severity. So it's designed with pain in mind, but a lot of those features can be applied to any other symptoms as well. PQRST is a slightly simpler version, and again can be applied to different symptoms, although primarily considered for pain assessment, with P being the precipitating and relieving factors, Q being the quality, R being the radiation, S being severity, and T being timing. And doing this will allow us to individualize care for our patients. So we come next to B, breaking bad news. And traditionally we think of breaking bad news as telling somebody that they have a cancer or another terminal condition or serious condition, but there can be lots of other things that from a patient's perception would be considered as bad news, not having the surgery that they've been admitted for, or the not being able to be discharged home on the date that they expected. And the same principles apply whatever the news that it is that we're breaking. And there are lots of different mechanisms and models for breaking bad news, and one that I like to refer to is spikes. You may be familiar with this, but if you're not, I'll talk you through it now. So S is about setting. So it's thinking about where am I going to break this news? Is there anything I can do to make this setting a better place? So do I need to take the patient into a quiet room, at least close the curtains if they're in a shared area? Is there somebody I can give my bleep to so that I'm not going to be disturbed during this period? P is perception. So what does the patient know already? What are they anticipating? Is this going to come out of the blue, or have they had some warning shots? I is invitation. So that's about going at the patient's pace, really, letting them invite you in and give you the go-ahead, really, to give the next snippet of information. K is knowledge. So we want to think about, do I know enough to answer these questions? Trying to anticipate questions that might come before you go in to see the patient, and consider the responses you might give. E is a very obvious one, empathy, and S is summary. And we have to remember, when a patient hears bad news, often after that initial phrase that's broken the news, there's so much going on in their head that they don't hear any of the other little bits of detail. So offering to summarize, offering to repeat at a later point that day or the next day is also really important. And just to demonstrate those points, I want to share with you this image. And this image was drawn by a patient that I cared for at the University Hospital of Wales about 5 years ago. And I was asked to go to see him to manage his nausea and vomiting. And the previous day, he had been seen by the surgeon and given the results of a CT scan, which sadly had confirmed that his symptoms were due to a pancreatic malignancy, one that was quite extensive and wasn't going to be suitable for any surgical intervention. And I noticed when I was seeing him, 24 hours after this news had been imparted, that he had sketched this drawing, and he was by his bedside, and I asked him about it, and he said, that was just me drawing my feelings last night, that's how I felt. And you can see in this image, the glass on a third story of the hospital is shattered, and you can see, if you look lower down, a gentleman's leg sticking out of the skip, and the speech bubble saying that the surgeon saying to the nurse, I think Mr. James has taken the news we've just given him very well, nurse. And I want to say that this patient felt that that surgeon had broken the news as well as he could. So he had no criticism at all of the way the news had been broken, and that surgeon had taken a nurse with him. He'd done lots of the right things. But that didn't stop this being bad news for this patient. It was still life-shattering, and I think that the glass shattering is just a perfect way of demonstrating that, really. It was life-shattering news for the patient. And that's why the take-home message from this slide is you can't make bad news good news. It is okay when you give somebody bad news that they are upset and crying. That's a natural response to bad news. It doesn't mean you've done it badly. It means you've been clear and they've understood the message. So don't worry about trying to make bad news good news. So C brings us on to constipation. And again, I go back to that point from the first slide, assessment. So before we talk about which laxatives to use, the first thing we need to do is work out what's causing this constipation. How long has it gone on for? What form is this patient's constipation taking? So is it that they're going very infrequently, but it's still actually quite a soft stool? Or is it that they've got very, very hard type 1, type 2 stool? And that's important because it's going to determine our choice of laxative. The main thing in our assessment is to exclude bowel obstruction, because the treatment for that is going to be very different, and we're probably not going to want to give a laxative, in particular a stimulant laxative, if the patient's got obstruction. So we want to rule that out in our assessment, as well as trying to find out more about the actual constipation. And then in terms of management, it's thinking about all the non-pharmacological things, the fluid intake, anything that we can do to increase their mobility. And also thinking then about the different types of laxatives. Does this patient need a stimulant laxative? So if their stool is soft enough but they're struggling to go frequently, they probably need a stimulant laxative like Senna or Bisacodil. If the patient is really struggling with a very hard stool and struggling to go, they may need a combination. They may need a stimulant and a softening laxative in the form of magnesium hydroxide or sodium docusate. So it's worth getting to know your laxatives and thinking about which one you might use in different scenarios. And my key message on this slide is that opioids are constipating. The mechanism of action of opioids means that they increase transit time through the bowel, and it's not a possible side effect, that is how they work. And so anybody who has opioids is going to be prone to developing constipation. And therefore we need to anticipate that, warn the patient that it might happen, and also make sure that they have the means to manage that. So they have laxatives at hand, they can start them immediately rather than run into difficulties. So D stands for use the D word. And D here refers to death, dying, died. It is calling it what it is. And I'll be showing you a video later on in this evening session, which will help demonstrate that in a very clear way. But what I'm trying to get across here is that if there's no ambiguity when you use the word dying, when you say, I'm sorry, but I think your husband is seriously ill, or your husband is critically ill, that can be interpreted in so many different ways. But when you say, I'm concerned that your husband's infection or your husband's stroke means that they may be sick enough to die from this, that's very clear for that relative to interpret. And if you're wrong and they improve, then that's fine. Everybody is so grateful that that outcome didn't occur. But when we don't warn people that things are serious enough that they may die or their relatives may die, then they miss that opportunity to mentally prepare, and that has negative implications on the grief and bereavement process for that individual. E is for escort, and this is really a very simple message to say that asking for help, taking a nurse in with you when you're seeing a patient, especially a challenging patient, or especially one that you're about to break bad news to, is not a sign of weakness. It's a really good thing to do for you, but also for the patient, because we come and go as doctors on the wards. We're not there late into the evening usually, or overnight. The nurses are, and they're then in a much better position to support that patient and their relatives if they've been part of those conversations earlier in the day. So F stands for fluids, or continuous artificial hydration. And when I'm talking about fluids, I'm talking about fluids in the last days or week of life. And there's very limited evidence guiding us one way or the other as to whether we should use fluids in this patient cohort. There is some limited evidence that fluids may worsen edema, ascites, and pleural effusions in patients with advanced cancer. But there's also some evidence to suggest that it may help with myoclonus and sedation in the final days. So there certainly is a requirement for more robust evidence to help guide these decisions in the future. So all we can say for now is the decision to give fluids or not must be individualized. It must be done on a patient-by-patient basis rather than any blanket decisions. And if we are going down the route of fluids, it should be a time-limited intervention where the benefits or the deterioration as a result of that fluid is reviewed at a set time interval, such as 24 hours after giving fluids. So G stands for get help. And I suppose similar to the escort slide, really, I'm getting a similar message across. If you're working in hospitals up and down the country, they will all have specialist palliative care teams of nurses and doctors based there. And if you don't already know them, get to know them. They are the people that you should be turning to, as well as the seniors in your own teams, when you come across any of these tricky symptoms or tricky scenarios. It's okay to ask for their help. They can work with you to help support patients and their families with current symptoms, but also to help plan and think ahead with these patients. Hypercalcemia is one of the few palliative care emergencies that we come across. It affects about 10% of patients with advanced cancer at one stage or the other, and it confers quite a poor prognosis for any patients that develop it. In fact, 80% of patients who develop hypercalcemia will have a prognosis of less than 1 year, even when that hypercalcemia is treated. It's most common in breast cancers, multiple myeloma, and squamous cell carcinomas. And the mechanism to bring about that hypercalcemia can be one of two different ways. One is tumour secretion of parathyroid hormone-related peptide, and the other is that tumour cells in the bones can activate osteoclasts, resulting in calcium release from the bones. So I should have said at the beginning, when I'm talking about hypercalcemia as an emergency in palliative care, I'm specifically talking about hypercalcemia of malignancy or tumour-mediated hypercalcemia, rather than primary hyperparathyroidism and the other causes of hypercalcemia. When it comes to managing hypercalcemia, the first question to ask ourselves is it appropriate to try and reverse it and manage it? If the patient is moribund and felt to be in the last days of life, it's likely that the hypercalcemia is a manifestation of that, as opposed to them dying as a result of the hypercalcemia. So that's a question to have as a team and with your seniors. But if it is appropriate to treat that patient and they've had an acute change as a result of this rise in calcium, then the mainstay of treatment must be IV fluids. And then if the calcium remains high, they are very likely to need for that to be followed with an IV bisphosphonate. Permethrinate or zoledronic acid are the usual drugs used for this. You have to remember then that the calcium level isn't going to come down immediately after administration of a bisphosphonate, and usually you need to wait at least 4 or 5 days for those levels to come down before you recheck them. So I thought if I'm going to do an hour-long session for you, you needed some breaks. So the I stands for interlude, and this is an opportunity for you just to stand up, stretch your legs, jump up and down, just to keep your energy levels up during this session. And I suppose also still getting a message across, and that is that we have to look after ourselves as well in our working lives, and it's important to give ourselves that time. And so the message here, self-care is not selfish. So if you've jumped up and down, you're feeling a bit more energized again, we can move on to J, which is for just in case medications, or the other term used for this is anticipatory prescribing or anticipatory medications. And so what we're referring to here, anticipating which medicines a patient may need, or just in case, in the final days of life. And so this is particularly relevant thinking about patients who wish to die at home. So patients that maybe are being discharged from hospital and they might not be imminently dying in the coming days or weeks, but they are expected to die in the coming months, maybe within the next 6 months, and have expressed that home is where they wish to be. We know there are certain symptoms that are quite prevalent in the last hours and days of somebody's life. So agitation, for example, and respiratory secretions, or what's sometimes referred to as death rattle, can be very common in the final hours. As high as 80–90% of patients might get some agitation or secretions in the last hours. And what you don't want in the community is for the family members to be rushing around trying to find a pharmacist open and to get these medications in those final hours. You want to help patients and their families be prepared have the drugs in place, avoid those crises calls, avoid the 999 calls ending up in A&E, prepare them both verbally to what to expect at the end of life and give them these tools, i.e. the medicines in the house. They'll often still need a district nurse to come out and administer them, but that's a much simpler process than trying to find somebody to prescribe the drugs and find a pharmacy to get them from. And quite helpfully, when we think about anticipatory medicines, we can think as a sort of checklist in our own minds how we prescribed everything that needs prescribing. Think of the 4 A's. A for analgesia, A for antiemetic, A for anxiolytic, and A for antisecretory. And I'll come on to antisecretories later on in the alphabet. And so for an analgesia, we would normally go with subcutaneous morphine, because we have to think in the final hours of days, it's very unlikely the patient would be able to swallow. So these need to be injectable medicines. And normally a low dose of 2.5 milligrams or 5 milligrams. However, if the patient is already on a different opioid analgesic or a higher dose, they may need slightly different dosing or a different choice of opioid, and your specialist palliative care team would be able to help you with that. In terms of anxiolytic, our go-to is normally a benzodiazepine, midazolam subcutaneously, and 2.5 milligrams as required would normally be our a standard dose. The antiemetic choice depends slightly on the patient and their diagnosis, and therefore the likely cause of nausea at the end of life. But if we can't really predict a particular cause for the nausea, often cyclizine 50 milligram subcut would be the go-to here. Okay, so I did say at the beginning that using the A to Z, I'd need a bit of artistic license. So this is one of those examples. So next we have K for conversions, and talking here about converting doses of opioids from oral to subcut route or from one opioid to another. And although I've got this table showing up on the slide, I'm not expecting anybody watching this evening to remember and take down all these numbers, because the main message I want to get across is that unless you're doing this day in, day out, and it's your job to prescribe opioids regularly, you're not going to be expected, and you shouldn't be expected to remember all these conversions. And even if you do remember them, it's good practice to check them up from a reliable source. So a conversion table or diagram such as this, or an opioid dose converter. And the handout that will be available alongside this session will have a hyperlink to an online opioid dose converter that can be very helpful as a check-in point. And the only other point that I want to make whilst we've got this slide up is fentanyl patches and their dosing. And I just want to make the point that fentanyl patches often appear to be very low dosing, because they're usually 12, well, the lowest fentanyl patches are 12 microgram per hour patch. So micrograms sound so small compared to the sort of doses of morphine that we're familiar with prescribing. And I just want to make the point that 12 micrograms of fentanyl, the very lowest strength of fentanyl that you can prescribe for a patient, is equivalent to 45 milligrams of oral morphine in a 24-hour period. Now that's a good dose of morphine, and given that some people might go straight into a 25 patch of fentanyl, that would be double that again, around 90 milligrams of morphine over 24 hours. And so just be very cautious. I think sometimes it's tempting to use a patch for an elderly patient who might struggle with compliance or with swallowing their oral medicines. And the patch isn't always the right way to go, especially in an opioid-naive patient. So we just have to be very aware of the equivalent opioid doses within patches. So L stands for lasting power of attorney, but I suppose a wider point here would be to think about the Mental Capacity Act in general and advanced care planning. And essentially there are 3 forms of advanced care planning that can occur within the remit of the Mental Capacity Act. One is that somebody draws up an advanced statement of wishes. And this isn't legally binding, but it is just a document where patients can express their wishes and dislikes on what they would wish for. They don't have to sign it, and they don't have to get it witnessed by anybody else. It can be on the back of an envelope or on a pro forma. Then the other two options are an advanced decision to refuse treatment, an ADRT, or a LPA, a lasting power of attorney for health and welfare. And both these are legally binding, and it's the LPA that I'm going to concentrate on here. So lots of people, I don't know if you've come across people, but lots of people will say, oh yes, I've got an LPA, or lots of relatives will say, oh, just to let you know, I'm mum's LPA, or I'm attorney for mum's LPA. And the first question, it's worth just having a bit of a checklist in mind, because these are legally bound documents. You know, we've got a duty to liaise with an LPA if it's a valid LPA. So there's a bit of a checklist to help you here. So the first point is it an LPA for health and welfare? So people can make lasting powers of attorney for property and finance, or for health and welfare. They can do both, but they are separate documents that are registered separately, and they would need to pay two separate registration fees to the Office of Public Guardian to register them. So you first need to ask, is it health and welfare? You need to see the documents. So taking somebody's word that they've got an LPA isn't enough if you're going to trust this person to refuse treatment for the patient. So you need to see the document, and when you see it, you want to check whether it has been registered with the Office of Public Guardian. It takes about 6 to 8 weeks to register an LPA, and so lots of people have filled the forms out and have never sent them off to be registered. And you'll know if it's registered because at the top of the document, as is shown in this image here, you can see the Office of Public Guardian date stamp at the top. And at the bottom of the document, in the next image, you can see that it says validated OPG. This is actually punched out, small little circles punched out to make those words at the bottom of every page of the registered LPA. So you need to look at both those things to confirm that it has been registered. You then want to ask who have been appointed as attorneys and how have they been appointed to act. So people can appoint a single attorney, then it's quite straightforward. But if they've appointed more than one, they can either appoint them to act jointly, which means that they both have to make decisions together. You can't allow one to make a decision without liaising with the other attorney, or severally, which means that either or. So as a healthcare professional, you can take the word of either attorney in a decision. Or, just to make things a little bit more complicated, they could choose to appoint them jointly for certain decisions and severally for others. Now, the next thing you need to look at in the LPA is, did the person making the LPA, what's called the donor, did the donor give the attorney right to make decisions about life-sustaining treatment? I have to be honest with you, I've never seen anybody take an LPA out and not tick this box, because most people would think, well, what's the point in registering one and paying the fees if I'm then not wanting this person to make important decisions. But it's still important to check that they've signed that box to say that they do give them the right to make these decisions, because alternatively we could sign the other box that says they don't give them right. So it's worth looking through the document for that. And then the final question is, has the patient lost capacity to make this decision? Because if they haven't, the LPA does not come into force. It only clicks into place when the patient can no longer make those decisions themselves. So M brings us on to our next palliative care emergency. So MSCC stands for metastatic spinal cord compression. So a serious palliative and oncological emergency, and one that's just always important to have on your radar. And the reason it's so important to think about MSCC is that early detection, early confirmation of a diagnosis and treatment has huge implications on the outcome for the patient. So if you can pick up MSCC before the patient has lost function in their legs, that patient has a much, much higher chance of keeping the function in their legs and not becoming paralysed than if it's picked up and treated when they've already lost that strength. So you want to look out for those early signs. Now, these two boxes have been lifted directly from a NICE guidelines for metastatic spinal cord compression, and the link to those guidelines are in the handout that I mentioned earlier. And these two boxes then, the one on the left shows the symptoms if you're suspecting a spinal metastases. And whilst this is still semi-urgent, and NICE guidelines suggest that these patients should have an MRI within 7 days, it's not considered an emergency. So you don't need to treat them like a metastatic spinal cord compression. You just need to try and confirm if they have got the spinal mets or not. Whereas the box on the right highlights the symptoms that might suggest this patient has metastatic spinal cord compression. And it's these group of patients that need to be managed urgently. They need to be immobilized, lay flat, given lower molecular weight heparin as a thromboprophylaxis, and high dose steroids to try and reduce any permanent neurological damage. And they also need an urgent MRI of the whole spine within 24 hours. And this should be possible because it's NICE guidelines and has been so for almost 10 or more than 10 years now. Radiology departments up and down the country need to be able to offer 24-hour MRIs for this purpose. So N stands for naloxone, and I'm not having a slide about naloxone to try and remind you all to give it. In fact, quite the opposite. I'm asking that you try and avoid giving naloxone unless it's absolutely necessary. So back about 6 years ago, NHS England became aware of a few patient safety incidents relating to palliative care, chronic opioid users having naloxone and having serious effects. In fact, there were 2 cases of death reports from those patients. And the important note here is that there are 2 different opioid regimes. Naloxone regime, one that you might give to a patient that comes into A&E having had an intentional or accidental large heroin overdose, but they're not a chronic opioid user. And then also your chronic pain and your palliative care patients who are on a long duration steady dose of opioid, who suddenly for whatever reason have too much on board. That could be because their kidneys are suddenly not working so well, so their standard dose is building up, or it could be that they've accidentally taken too much in error or on purpose. And the risk is, if you treat them the same and you give the palliative care cohort of patients a high dose of naloxone, as you would give the A&E patients, then you may rapidly reverse the pain relieving benefits, resulting in a pain crisis, which might cause an overdrive of their sympathetic system and result potentially in hypertension, cardiac arrhythmias, and worst case scenario, a cardiac arrest, as it occurred in a couple of these cases that brought this patient safety alert about a few years ago. So the advice now is that we should only give naloxone to these patients if their respiratory rate is below 8 and they're hypoxic. If they don't meet this criteria, we should just watch and wait, not give them any more opioids, let it wash out of their system, and keep an eye out for a change in respiratory rate or hypoxia. If they do meet that criteria and they do need naloxone, then it should be given in small doses. So normally the vials would be 400 micrograms in a ml, and whilst you might give the whole lot in one go to your A&E heroin overdose patient, for our palliative care patients, we would dilute that 400 micrograms in a ml up to 10 mils. So every mil is the equivalent of 40 micrograms, and then give it in 1 to 2 mil increments until you get the desired effect. But doing it that way will avoid that acute pain crisis and the potential detrimental effects from that. So my take-home message is avoid giving it if you can, And if you do need to give it in low dose. So O, I have for ondansetron, but I'm quick to add or not. So again, like the naloxone, I don't want you to take the message home from this slide, oh, I need to start prescribing ondansetron. In fact, it's quite the opposite. I'm keen to impress that we try and avoid using ondansetron in palliative care as much as we can, because it's severely constipating. So there are very few cases that we would find it appropriate to use ondansetron for. So what I really want to use this slide to do is just to highlight another very common symptom in palliative care. About 62% of patients with advanced disease will describe nausea and vomiting as a problematic symptom for them. But one of the important things as a starting point is to define what nausea is and what vomiting is. And lots of patients will say, I'm feeling sick, or I'm nauseated, but actually when you drill down,
And in my humble opinion, dying's probably not as bad as you're expecting. We've stopped talking about dying. We've stopped mentioning the D words. Instead of saying dead, we say passed or passed away. Instead of saying dying, we might say seriously ill. And families don't understand that death is approaching when those words are used. And that is in fact a bit of a problem for us. And so now a family will sit around the bed of somebody so sick that they will be dying and not know what to say. Not know what to say to each other, not know what to say to the dying person. And the dying person doesn't know what to say either, and doesn't know what to expect, wondering whether each breath might be their last breath. A scene of sadness and anxiety and despair. And in my humble opinion, it doesn't need to be like that at all. We've lost the rich wisdom of normal human dying, and it's time for us to talk about dying and reclaim the wisdom. What does normal dying look like? Well, dying like giving birth really is just a process. Gradually people become more tired, more weary. As time goes by, people sleep more and they're awake less. Families can learn when to give medicines and when to introduce visitors. But sometimes a visitor might happen or a medicine might be due during that sleep. And that's when we can discover that a change has taken place. It's tiny, but it's really significant. And it's that instead of just being asleep, this person has temporarily become unconscious. We can't wake them up. We can't give them that medicine. We can't tell them that that visitor is here. And yet when they waken later on, they tell us they've had a good sleep. So we know that this coma doesn't feel frightening, that lapsing into unconsciousness just isn't noticed by us when it happens. So as time goes by, people are awake less and asleep more, until eventually they're just unconscious all the time. We'll be so relaxed that we won't bother to clear our throats. So maybe we'll be breathing in and out through little bits of mucus or saliva at the back of our throat. It can make a rattly, funny noise. People talk about the death rattle as though it's something terrible. But actually it tells me that my patient is so deeply relaxed, so deeply unconscious, that they're not even feeling that tickle of saliva as their air bubbles in and out through it from their lungs. So at the very end of somebody's life, there will be a period of shallow breathing and then one out breath that just isn't followed by another in breath. Sometimes it's so gentle that families don't even notice that it's happened. So normal human dying, just a really gentle process, something we can recognise, something we can prepare for, something we can manage. And this should be something we can celebrate. This is something we should be able to console each other with. But because it's become impolite to talk about dying, it's the really best kept secret in medicine. So, in my humble opinion, dying is something we should be reclaiming, we should be talking about, we should be consoling each other about. Please pass that on.
So she's so easy to listen to, and I think gets the message across beautifully. And so the take-home message here really is that we need to try and constantly try and normalise the dying process and help patients and families prepare. So Q is for question, and this is twofold really. One, our role to invite questions, to make sure the patients can ask us anything that they don't understand and that they feel free to do that and to have those open conversations with us. But secondly, for us to ask some questions, for us to ask patients what they want, what they do and what they don't want, to help them prepare for now, but also for what they want in the future and what advanced care planning brings. So the message here is that it's our role to initiate open discussions with our patients so that they can freely talk to us about their wishes. So R stands for resuscitation decisions, and I suppose I couldn't do a palliative care talk without talking about this. And I think COVID and lots of the media discussions during the course of this year have really brought it to the headlines even more, and we've heard about GPs sending letters out to patients talking about resus decisions, and nursing homes asked to consider DNA CPR decisions en masse for their residents. So there's been quite a bit of bad press, but I think in general there have been lots of really proactive, good discussions that have taken place. And in fact, I take a lot of the information from this slide from a very recent opinion piece in the BMJ by David Oliver. And he refers to CQC's announcement in England that they plan to review how resuscitation decisions have been made during COVID. And really, he urges that if decisions have been had, that in itself is a good thing, because it shows that discussions have been had. And they should be more concerned about the people who didn't have those discussions and decisions, rather than trying to review the people who have had DNA CPR decisions made. And so the key messages that he talks about us needing to try and get across to the public and also to other healthcare colleagues, if we're going to try and improve this public conversation around resuscitation, are as follows. So 1, DNA CPR is not the same as do not treat. And it's really important, even if we know they're different, not to assume that patients, when we talk about resus, know that they're different. So we really need to make it clear that those decisions only relate to resuscitation, and that doesn't mean that we wouldn't give antibiotics or fluids, unless there's another reason to say that they wouldn't be appropriate. But when we're talking about resuscitation, we need to be really clear that we are only referring to the act of trying to restart the heart and get the patient breathing again if they've had a cardiopulmonary arrest. 2, so CPR affords a low chance of survival, and unfortunately, TV and film don't always give this message out. So we need to be really clear with the public and with patients that the chance of surviving a cardiac arrest are very low. The chance of surviving a cardiac arrest out of hospital is even lower, and the chance of surviving a cardiac arrest that is due to non-cardiac causes is lower still. And so we need, we can't expect them to make informed decisions unless we're very clear about this with patients. And 3, CPR is not a benign intervention. It is, we don't see that often, again in TV and film, but arterial puncture and broken ribs and sternums and intubation, they are not dignified, peaceful ways to end somebody's days. So if the chance is very low, it is not the right thing in most circumstances to offer resuscitation, if that's the case. Okay. And the planning ahead, having these conversations before the crisis hits, pre-hospital ideally, is a good thing. And this goes back again to the comment about CQC's plan to investigate these decisions. Okay, so it is a good thing if people have offered patients the opportunity to have these conversations early on. So S is for secretions. I said I'd come back to this again. So some people will call this noisy breathing, some will call it death rattle. So we're talking about upper respiratory secretions in the last hours, days of somebody's life. Again, we go back to assessment and the importance of trying to assess, well, are they upper respiratory secretions, or is there a chest infection or pulmonary edema causing this? And are they distressing the patient? Because if they're not distressing the patient, then we don't necessarily need to treat it. And when I say treat it, we're talking about there are antisecretory medicines out there. You may be familiar with them: glycopyrronium, hyoscine hydrobromide, and buscopan. But the evidence for using these drugs is not great. They all come with side effects. They are not always the right thing to do. What's far more important is to have those discussions. And as we heard beautifully in the video from Dr. Mannix earlier, and I'm going to use her phrase again because I think it's fantastic, really. It tells me that my patient is so deeply relaxed, so deeply unconscious, that they're not even feeling that tickle of saliva at the back of their throat. And that is a sentence that I have used several times in the last couple of years since reading her book and hearing her talk, because I think explains it perfectly, and also normalizes this part as a very normal part of dying, these noisy breathing. And if we don't give those explanations, if we don't explain this to patients, and in particular to their relatives, they might be left thinking that the patient, had a terrible death and drowned in their own secretions. And that might sound dramatic, but I've certainly heard relatives use that description. So it is our role as doctors to talk them through that process and to explain that this might happen, even preemptively before it happens, but certainly if it is happening, to explain why it's happening and what it means, and that it doesn't necessarily mean that the patient's distressed. So T is for trajectories, and really the point I want to make from this slide is quite simple, that patients, depending on their diagnosis, will die by different modes, really. And it's not quite as simple as just 3 different graphs, but this does demonstrate it very broadly. And so patients with cancer will often have a very steady path until they get to the point that they're no longer suitable for active anti-cancer treatment, and they may then start to deteriorate quite rapidly when they're no longer having treatment and the cancer is continuing to grow and progress. And that's where we see that sharp drop in the top blue graph. So I should explain the y-axis here is their function, level of function. So obviously 0 at the bottom line is when they've died. And then we've got time across the x-axis. And then the next graph down is the one that we see for the failures, if you like, the patients with the respiratory failures, COPD or pulmonary fibrosis and a heart failure. And with these patients, they might get an exacerbation and they get a sharp drop, and they might have IV diuresis, or they might have IV antibiotics if it's a COPD infective exacerbation, and then they make a recovery again. And what's really challenging with these group of patients is to know which dip is the final dip, and which dip are they not going to recover from, and it's not always easy to tell. And that's particularly difficult when you're advanced care planning with these patients. So if they say they want to die at home, but they recover well whenever they go in for antibiotics, it's really difficult to try and work out which infection, which deterioration you shouldn't send them into hospital for in order to try and achieve their wish of dying at home. And the bottom graph is the picture that we see in patients with dementia and frailty. So they already start at a low level of function, they sort of grumble along with a gradually deteriorating function until the end of life. So the word I've chosen for one of my messages here is uncertainty. And again, there are 2 ways of interpreting this word within palliative care. And one is for us as professionals, whether it's palliative care or any other form of medicine, just to be comfortable saying, I don't know, I'm not sure. And it might be, I'm not sure, but I'll look it up for you and get back to you. Or it might be, I'm not sure, and nobody can give you those answers. And we need to be comfortable saying that and explaining that to relatives, rather than desperately wanting to please and saying something, rather than being honest and saying nobody knows or I don't know. And the other element of uncertainty is just being aware of the emotion amongst our patients. It is a really difficult emotion for our patients to have to deal with. But when patients do open up to that vulnerability and talk about how difficult living with uncertainty is, it can often be a way in to advanced care planning. So we can often say, yes, it is difficult not knowing what's going to happen and how quickly things might change. Why don't we plan for the worst and then hope for the best? So you can do that planning, you can consider all these potential outcomes, all these bad things that you know, the worst things you might be thinking about, and then you've done that planning, you can park it aside and you can focus now on hoping for the best. So I couldn't do a palliative care talk this year without talking about COVID and and its impact on us as a specialty. And the aspect I've decided to pick up on here is the impact of PPE on communication. And I'm sure every single one of you will have experienced this yourself. And this infographic that's up on the slide is from the British Geriatric Society, and I think is quite a nice, simple infographic to look at and to follow. And my key message here would be, you know, we might not be able to show our mouth, and we know our mouth does a lot of our communicating, but we've still got our hands. We can still use our eyes, more importantly. Therefore, make it as easy as possible for patients to see our eyes, drop down to their level, open up your eyes, show your emotions and your empathy through your eyes, and any other body language, just to try and aid that communication. You will usually need to raise your voice, even if the patient isn't hard of hearing. There's so much muffling between a visor and a mask. And think about how you might be able to identify yourself. And you might already be doing this, but writing your name on your visor, or having a clear name badge, or even a laminated picture of yourself without PPE. So I've chosen the World Health Organization analgesic ladder. So this has been around now for 30 plus years. It was in the 80s, and it hasn't really changed much in that time. The principles are still very much the same. And they are that when we're prescribing analgesia, and this was written with advanced cancer pain in mind, that we should prescribe by the clock. So give regular analgesia rather than wait till somebody's got pain and give them PRNs. So anybody with pain should have it managed by regular analgesia. By the mouth, if that route is available. It's certainly, we think these are World Health Organization rules, and so oral analgesics are always going to be cheaper and more widely available across the world. So by the clock, by the mouth, and by the ladder. And the ladder simply means that we start at step 1 and work our way up. And if one drug at one step of the ladder doesn't work, there is no benefit in switching to another drug at that point, unless it's side effects, meaning that they can't tolerate that drug. But if the drug isn't helping the pain, that's your sign that you need to move that patient up to the next step of the ladder. And as well as these drugs at these steps of the ladder, you can always add in an adjuvant analgesic. So by that I mean, if there's a particular neuropathic element of their pain, they may need a neuropathic agent such as amitriptyline or duloxetine or gabapentin added in. And I'm also just going to take you back to letter C, and you'll remember we talked about constipation and opioids, and the message again, that if you're starting a weak or a strong opioid, it will slow the bowels down. Think about co-prescribing a laxative. So X stands for xerostomia, which is the technical term for dry mouth, but also very convenient because I don't know what else I would have used to represent the letter X in this alphabet. But it is a very common symptom in patients with advanced disease, often underreported because they feel they shouldn't be bothering a doctor with a dry mouth, and they need to reserve their time to talk about pain and nausea and vomiting. Yet when you survey patients with advanced disease about dry mouth, more than 3/4 will say that they are troubled by a dry mouth and that it impacts on their quality of life. And having a plentiful supply of saliva is so important to so many functions, such as swallowing and talking and tasting. Another key element of assessment is taking a good drug history, and the pop-up shows that the list of drugs that can cause a dry mouth. And the importance to try and think about whether if the patient's on any of these drugs, could any of them be stopped? Cyclizine is a prime example of a drug that causes a dry mouth. In terms of management, we've talked about reviewing medications and de-prescribing where possible. Artificial saliva, chewing gum and pilocarpine are all treatments with some evidence from a systematic review, albeit weak evidence. And chewing gum is considered because the action of chewing induces production of your own saliva. And my take-home message on this slide is that if you've got a patient with oral thrush, and we know that patients with dry mouth are more prone to developing thrush, so if you have a patient with oral thrush and they wear dentures, be sure to treat the dentures for thrush as well. Otherwise, you're giving treatment for the thrush and you continue to reinsert the dentures every day and reinfect the patient. And the normal treatment is to soak them in chlorhexidine for 10 minutes at night and then allow them to air dry. So why brings us back to you and self-care again. And then I think there are some great analogies out there explaining why taking care of yourself is so important, you know, and we talk about you can't pour from an empty cup. And another one I like is self-care isn't about self-indulgence, it's about self-preservation. And I think my favourite of all is you need to put your own oxygen mask on first before helping others. And of course, our natural instinct as caring profession, you know, if there's a child or an elderly person next to us, is to help them first. And that's why I like this analogy, because actually, if you haven't got enough oxygen going into yourself, you can't help them, and really hammers home the importance of looking after yourself. Now, how you do that will be unique to you. So for some people, it'll be music, for some people it'll be sport, for some people it'll be something else, but you need to make time for those things to get that balance right. So we come to the end of the alphabet. For Z, I've got zoomorph. Now, zoomorph is the trade name for one of many sustained release morphine drugs, others being MST, Continus, Morphgesic, and MXL. And I suppose the point I'm trying to make from this slide is there are already lots of different generic opioids out there, but when you add in the trade versions, there are even more. And we can't be expected to know them all off pat and to know which ones are sustained release and which ones are short acting. But it is important, if we don't know, if we see a drug we don't know, to look it up. There are thousands of opioid incidents reported within the NHS every year. And a National Patient Safety Review back in several years ago now actually looked at over 4,000 opioid incidents, and most of them were in inpatients. Most of them involved morphine, which isn't surprising because it tends to be the most commonly used opioid. And about 2,800 of these 4,000 incidents were linked to issues with administration, which tends to be more on the whole linked to nursing colleague errors, but 771 were linked with prescribing errors. We've talked a bit about opioid conversions already and the importance of looking that up when we're unsure what to do. But the message here is, if you don't know the name of a drug or you see a drug, and this applies to non-opioids as well, but I suppose I'm making the point with opioids, look it up. Look up the mechanism of action, look up whether it's sustained release or immediate release. Otherwise, you know, a patient says, oh, I'm on morphine, and maybe they'll name the old morphine they're on, MST, and then you copy the drugs and they're on a drug called Zomorph twice a day as well, and you put them on that, and before you know it, the patient's had more opioid than they should be having and that was previously prescribed. So really just the importance of confirming recent doses and being familiar with the medicines. And if you don't, look it up or ask a colleague, pharmacist or specialist palliative care clinician. So I did warn you this would be a bit of a marathon, so thank you for sticking with it. And I suppose I could have given a very long list of key messages, which is the handout really, but here I just want to get repeat a few key messages. This phrase, that somebody is sick enough that they may die, is really valuable to use and to get comfortable using those words and saying those words when that's what the clinical team think. Secondly, to practice describing what normal dying looks like, you know, and listen to Dr. Mannix's short video again if need be, but just get comfortable, familiar using those terms, talking a family through what to expect and why it's happening. And the third is look after yourselves. That's really important at all times.
Thank you, Dr. Seaman. That was an amazing talk and a great look into palliative care and its principles. Please do post your questions in the dedicated Slack channel if you want to ask Dr. Seaman anything regarding her talk this evening. Our next speciality talk, coming in December, will be looking into neurology and will be provided by Professor Phil Smith, a consultant neurologist also based in Wales in Cardiff. Please look out for our future speciality webinars through the coming months and in the new year, and for all the other materials provided by Medics.Academy for foundation year doctors. You can find out more information about the services that we provide on www.medics.academy. Thank you very much for tuning in, and have a good rest of the evening.